So Mike, in patient-reported outcome, is that just the review of systems? I mean, what is going to be different in PRO versus what's been done historically? Is how do you feel? How well you get, how well you're functioning, the performance level, and then are you having cough, are you having diarrhea, are you having whatever else?
So there's actually excellent evidence that a physician assessment of patient performance status is a very poor surrogate for actually how well the patient is performing. So as Scott said, and I think this is absolutely true and actually is the challenge, the kind of questions and how we collect the information and operationalize it into shared decision making, for example, does not exist yet, but that doesn't mean it won't. So for example, when you go for your 60th visit, the question will become, should I have PSA testing? And the thing will be that at some point in the not so far future, how you grade that interaction with your physician will be collected, and input regarding how people like you process that information, what they find useful in that discussion, will be presented to the physician so that they can enhance that total morass of PSA testing. But the tools don't exist yet, and they're not integrated into the workflow yet.
It's not just the, it's
Well,
not,
I want to get Brian only because I'm really curious from the health plan side. How is that going to impact the way you're going to change reimbursement design?
I think if we have good tools and we have objective and something that's objective, we can begin to incorporate it into payment plans. I mean, this is a form of medical quality, fundamentally. What we're talking about here is physician satisfaction, physician interaction with a patient. And we've not been good at measuring, as Scott well knows from his experience in CMS, the classic quality measures that we have, they don't really correlate well to outcome. So one of the problems we have when we're trying to assess care and assign payment to high quality care in all the domains of quality, including technical quality, interpersonal quality, the delivery, efficiency of delivery, is we need good measurement tools. So I think that once we have developed that, I think that's very important. And I think once we develop those systems and have reliable, reproducible, valid tools, and in this area they have to be culturally relevant, they have to be linguistically relevant. There's a lot of challenge in doing it.
You just made a list that is so long that to accomplish all that you just described, it sounds like it would be 2 decades before we have resolution.
But there already are some.
I want to say that the interesting thing, and I agree with everything that's being said, but if you take a look, and you ask the question, Bruce, and you say specifically, how is it different, how is it being implemented right now? I think if you look at Dr. Barbara McEnany's CMMI Come Home grant, and you look at the 7 practices that are involved in that, you're seeing some pretty radical fundamental changes. So very specifically, patient comes in the door, okay? Maybe a lot of places you get a patient satisfaction survey, but there's not a lot of places where that survey actually allows within the practice to benchmark physician against physician on some very key things. Then you go in to see the physician. Well, instead of having a nurse navigator, like a dedicated nurse navigator, that function of nurse navigation is built throughout the practice. So all of a sudden, the patient is put first in that. There are a number of measures that are very specific. In fact, as Mike knows this, there are 19 measures of quality and value that are actually being incorporated into the EMR systems of the practices. And the interesting thing is, when that patient basically leaves the practice and goes home over the weekend, and all of a sudden there's an event. Now think what normally happens, okay? You're the physicians. Patient basically has an event. They usually call, they get an answering service. Answering service puts someone on board, and basically they may have to go in to get hydrated or something, and they're in the hospital, in the emergency room. Not a good place for an immunocompromised person. Well, in those practices, there's 24/7 access to someone who basically has the chart, knows what can do, can talk to the patient and not just take a phone number and have them call back. So there are a bunch of other things, but what's really fascinating about this and what we're seeing is sort of a sea change actually being implemented right now on a real basis. Not just a bunch of hype, not just what may come down, but what's happening really right now.